Welcome. Thank you very much for joining us for this latest evidence and implementation webinar. My name is Stephanie Best. I'm an associate professor at the University of Melbourne, and my area of work is around implementation science. And I'm the one who has the great pleasure of taking you through our discussions this evening, this morning, wherever you happen to be. But before we start, I would just like to acknowledge the traditional custodians of the lands that we're on. For me, here in Melbourne, it's the land of the Wurundjeri people of the Kulin Nation. And our First Nations people have been in here in Australia for many, many thousands of years. And I would like to pay my respects to their elders past, present, and really welcome any First Nations people that we have on the call today. Now, before we dive into the discussion that you can see flagged here on the slide, I'd just like to share with you where we're up to with the Evidence and Implementation Summit, which will be held here in Melbourne in October later this year. So really excitingly, for the first time ever, the Implementation Science Conference in Health Australia, or ISHCA, as we often call it, is joining forces with the Centre for Evidence and Implementation. And we're going to be delivering an international conference covering all things implementation. So obviously you can imagine the plans are well underway, but we want to hear from you. We have the call for abstracts open and also for pre-summit workshops. So those expressions of interest, they close a little bit quicker. So we need to get you on the ball with those. And just first, you're the first people to hear this, but we've just opened registrations. So would really take a look at the website and you'll see all the exciting things that we're going to be getting up to in October. A little housekeeping, just to let you know that the recording will be available from this session towards the end of the week. And I've no doubt while we're talking tonight, there'll be various sort of links and papers and things that might come up. And so we'll endeavour to put some of those in with that recording as well, sort of at the end of the week. Although I have got the great pleasure of hosting this discussion, really, I would welcome your questions. So please pop them. You'll see the Q&A function at the bottom of your Zoom screen. If you pop the questions into there, I've got that Q&A screen open on my window. And I know that the team that we have here today are really keen for this to be an interactive session. So now we've got all that out of the way, to business. Today we're talking about creating impact and moving beyond the hospital walls. And it's clearly a topic that resonates with all of you because we've had over 300 registrations and from people from over 30 countries, which I think is really quite exciting, that there's so many of us that are thinking about this topic. In this session, we're going to be thinking about health. And we're going to be starting to think about extending care beyond traditional healthcare and start considering community outreach, examining partnerships for change, bringing in and thinking about the wider social determinants of health. I'm absolutely delighted to be joined by two esteemed colleagues who both have absolutely fabulous track records in implementing change in health within and beyond the hospital walls. We're joined tonight by Professor Annette Boaz from the King's College London and Professor Harriet Hiscock from the University of Melbourne and also the Royal Children's Hospital in Melbourne. Welcome to you both. So, if I can kick things off, perhaps, Annette, if I could come to you first, would you like to just share a little bit about yourself so the audience knows a little bit of your background? I mean, I know your work goes before you, but perhaps if you could share a little bit of that.
Sure. So thanks for having me. I'm looking forward to this discussion. So I'm a social scientist by background, and I've had throughout my career just a really strong interest in how we can make research more useful in terms of improving health and social care services. And this has always extended beyond the hospital, I think primarily because I'm very interested in the role of stakeholders, and they always ask us those wider questions, their kind of interests and priorities, whether they're people delivering services or people using services, stretch beyond the hospital walls. So I think this has always been an interesting theme, but really interesting to see it becoming a kind of, well, certainly in the UK, a kind of national priority area as well. So yeah, so that's where I'm coming at this from.
Excellent. Thank you very much. And Harriet, could I come to you? Would you mind just sharing a little bit about yourself for the audience in our over 30 countries?
Yeah, sure, Steph. So I'm a pediatrician and I still practice as one looking after children from birth to 18 years. But what I've really been doing for the last 20 years is looking at health services and system solutions and how do we keep kids out of hospital, improve access to care that's high quality care in an evidence-based way, and how do we also look at the social determinants of health, which you alluded to, because I think traditionally in health, we've been quite siloed in thinking about healthcare systems and delivery of healthcare, but that misses a lot of the issues, particularly around equity of access and how people can and can't get to care if we don't look at the social determinants of health. And for kids, we'll talk about it later, but I've done quite a bit of work in childhood adversity, and you have to start thinking about broader families adversity in that context. So that's where my passion comes from. And I think working as a clinician, I see the problems every day and I can help one family at a time. But when I do my research, I can hopefully help hundreds to thousands of families at a time.
Fabulous. Thank you very much to both of you. That's a great introduction and beautifully diverse backgrounds that you have there, which I think is really going to add to the richness of our conversation this evening. So the first question that I would like to pose to you is really, I mean, you've both alluded to the vastness of the issues that we're thinking about here. How do you go about identifying need? And then really that next step, how do you go about prioritizing that need? Um, who would like to pick that up first?
Well, I can start with an example, and I'm sure Annette will have many examples. So, a recent piece of work that we did, I guess the identifying need was really because there had been a grant funding round. So that's a different way of saying this is a
Mm.
problem. And it came out of one of our national mental health service and advocacy bodies, Beyond Blue. And so they put up money on the table around childhood adversity. So when you think of childhood adversity, adverse childhood experiences, it's anything from things happening in the home like domestic violence, child maltreatment, drug and alcohol use, to things happening outside the home like financial and housing instability. And so one of the things we did was we ran a 2-day national symposium with people with lived experience, health, social care, education, and justice sectors. And we had this grand title of What Should Australia Do About Childhood Adversity? But we broke that down into what should we do from service provision point of view, from a policy point of view, and also from a research point of view. And we had the luxury of being able to bring people together actually in person post-COVID over 2 days to really bubble up a whole lot of ideas around that. And we ended up with over 200 ideas that we then had to go and synthesize further. And I often use that FINA acronym. Is it feasible, interesting, novel, ethical, researchable? And using that filter, we were then able to go out again to that nationally with a sort of national priority setting survey. And we had all those ideas, but we distilled them down into sort of a manageable amount of 10 in each of those areas. And then our survey, we said, here's 10 priorities in services. If you had 100 units of resources, be that people, time, or money, where would you put your resources? And out of that, we came up with some clear winners in each of those 3 areas of research, policy, and services.
Mhm. And I really like that FINA acronym. I think that's just a really beautiful way, isn't it, to sort of be starting to filter sometimes we have lots and lots of different ideas. Tell me, you had consumers and families involved in this.
Mm.
How did they engage with, because they're quite high level things to be thinking about service policy and research. How did they get to engage in those 3 areas?
Yeah, look, I think we did it in a couple of ways. There were consumers there on the day. And as you say, it's a pretty sophisticated conversation and it can be really
Yeah,
daunting.
yeah,
So the consumers we had from our national organisation were perhaps more familiar with this work, a little bit further on in their journey from having experienced adversity as a child and were in that solutions focused thinking phase.
yeah.
In retrospect, some of the other consumers that we had from a mental health lived experience network were still quite in their trauma, and I think they found it harder to respond and engage, and that's one of my many lessons learned. But we also did send an anonymous survey out to that network, which is over 1,000 people. So we got responses back for that then we were able to look at themes and present those themes as part of the symposium as well. So it was really a combination of the ability to respond anonymously through a survey, but also be there in person. But that second one, you need to support your consumers, particularly for a topic like this.
No, absolutely. And I think that's beautiful. So it's sort of about giving people multiple opportunities to engage. But that's a really important point, isn't it, about ensuring that our stakeholders are able to come to the table and give as much as I'm sure they probably would like to. Annette, I know, you've done a lot of work with stakeholders and stakeholder engagement. I wonder what your thoughts are.
Yeah, I mean, like Harriet, we've had the experience of doing a very intensive process around mental health, and despite an awful lot of kind of work and attention being paid to supporting people with traumatic experiences to be part of that process, I don't think we handled it well enough. And I think that needs such careful consideration, because in processes of prioritization, obviously all those very different interests are coming into play. So everyone's interests will be balanced or hopefully will be balanced as part of that process. And I think it was so important bringing that lived experience into the prioritization process, but how you scaffold that, support that fully, because we had thought about it and we had put things in place, but I don't think they were enough. So I think that I agree with Harriet. I don't think we can underestimate, when we go out and try and work with a broader group of stakeholders, just what amount of careful work is needed in that to do it well, and to do it without adding to people's already very difficult experiences.
Mm-hmm. And I wonder, I mean, you've obviously both put a lot of thought to this, but how we can improve on that? How can we be, whether confidence is too high an aim, but as researchers, wanting to engage a wide group of people, the steps that we need to be thinking about putting in place to ensure that our potentially vulnerable consumers are as well supported as they can be?
I think we're getting better at it, and I think there's a number of toolkits out there, within Australia, and I'm sure within the UK as well, and we can share those later on. So there are some more almost step-by-step guides now and considerations. There's nothing like speaking to someone who's done it before, learning from their experience and saying, what did you do? What worked? What didn't work? As you know, Steph, we've got an upcoming series of forums, and I've actually spoken to each consumer in person or on the phone, and that's enabled me to share a bit about myself, hear a bit about them, ask them if they, describe what we were hoping to get from them, and ask them if they would be feeling comfortable in that sort of playing that role and what we can do to support them. So I'll see if that works and plays out, but I didn't do that last time, and I think depending on how many consumers you have, picking up the phone is another way. And then I think just being aware of your numbers. I think we've had experiences where you go along and there's 2 consumers in a room of 50 people, and that's not a really welcoming ratio. So numbers is very important as well, and obviously because that, thinking about those power imbalances from the get-go.
Power, absolutely. And I like that approach of sort of contacting people. I don't know, Annette, is there anything further that you'd like to?
No, I would agree. I think we are getting better, and these tools that are out there help, and the things that help you think through a process. I think probably we underestimate the time involved to work really well with stakeholders and to think about their timelines and processes rather than ours as either providers of services or researchers. I think one of the dangers in implementation science, and it'd be interesting to think what people think of this, is that we do have a little of a tendency to a kind of hyper rational way of presenting things, so that you will be participating in an incredible, whereas however much you try, still the kind of politics and power elements come into prioritization. So even when we've been through this incredibly rigorous process, still powerful argumentation can prevail, or important interests or shifts in the external context And we know all that, but I think we can sometimes present this idea that we're going through such a scientific process that it will definitely result in a particular kind of outcome if you just follow the science, whereas that's not what happens with the kind of real world context we're working in. It happens very little in hospitals, and is going to happen even less so, I would say, in the kind of wider community, where there are even more kind of interests to balance and different types of services with different kinds of resources and different kinds of challenges.
And can I just take you back, because you were just saying there that we often underestimate time commitment. Is it, when you say that, is that about just the physically participating in an interview or a focus group, or is it about a consumer coming on board with whatever the topic is that we're talking about? How were you thinking about time in that context?
Both of those things. I think it takes a long time to build up, to do the planning and to build up a really participatory process. And then it does take a lot of people's time to, so, you know, in the UK, we particularly have kind of, you know, strong ideas around resourcing that. So making sure people are appropriately rewarded for the time they give into processes, certainly, and people with lived experience. So there's a recognition of the time people are giving, but also it just really does take a long time to do something more meaningful in terms of engagement.
Absolutely, and you're right. Yes, we have similar remuneration sort of schemes that they're all different for every hospital and every university. I don't know whether that's the same in the UK now, but here it's sort of, yes, very challenging as a researcher to try and identify which is the approach that you should be using. Thank you. So we very much went down that sort of stakeholder line. Annette, I wonder if I can come back to you and talk maybe a little bit more about that sort of prioritization, and if there's any processes or projects that you've been through where you've undergone that kind of activity to prioritize what it is that we should be doing next.
Yeah, so I'm very interested in prioritization at the moment, and I'll share the resource around this. We've been doing a global WHO exercise about what the research agenda is in this area, and so that's been really interesting, going through a kind of Delphi consultation, all online because it's a WHO community. And I think, as Harriet said, that there's something about the in-person of this kind of work that is really powerful, and so how you make that work online has taken quite a lot of work. So we've done a few bits of prioritization. I guess the gold standard we sort of typically here is the kind of James Lind Alliance process, and spent a bit of time talking to them. And I thought it was really interesting that even there, where they have a very strong process, they kind of recognize that it's really about going on that journey. So it's about working together and engaging with people and listening and talking and learning about each other's contexts and needs. That's the most important bit. And sometimes, you know, obviously you come up with something at the end, but the journey is so important. And so how that journey feels for people is even more important, as we were talking about at the start. So I think that was a really interesting learning for me, because I kind of assumed, because they have such a clear product at the end, that they were quite product orientated, but it really was about the journey as well. Wow. And then we've done this.
Can I get you to hold your next example? And I'm just thinking, you know, I'm mindful that with the over 30 countries that we've got sort of on board for this. I wonder if you could share a little bit about what the James Lind Alliance are and what their sort of aims are, how they work, that kind of thing.
Yeah, so James Lind Alliance do a kind of very structured prioritization process with a group of stakeholders, and they come out with a short list of priorities that is incredibly useful for engagement of kind of different stakeholders in the community. So they work particularly with patients and people with lived experience. And yes, the idea is to set a kind of clear agenda or in a particular topic area. So they bring together people with a very strong focus and work through a kind of very transparent process of prioritization, and then share those. And it's quite a short list. So it's I think it's a top 10 kind of priority areas. So I think that's been a really interesting addition in this space, and they now exist on a wide range of topics.
Fabulous. Sorry, and I interrupted you. You were just about to give us an example.
But we could definitely share links to that for people to have a look at.
Great idea.
Yeah, and then we've been on this kind of, I would say, more of a researcher-led journey in mental health work. But what was interesting about that was I guess in researcher-led journeys around implementation, we're often very preoccupied with the kind of evidence, what are the best interventions? But in this process, we're also looking at interventions which were seen to be promising in a kind of clinical setting, in a research setting, but also had evidence of their implementability in the real world. All of which are outside of hospital. They're, kind of, there's an agenda which is around people with kind of very complex needs. There's one that's around kind of people's experience of kind of racial abuse in the system. And there's one which is around kind of parent-led cognitive behavioral therapy. So they're all things that are out there trying to really ease and help people work with the system. So I think that was a really interesting process of kind of coming up with those priority areas and thinking through very carefully what those might be, and really putting a lens on the implementability of things in that prioritization process, and saying this is beautiful as intervention, but this is and I thought that was a really nice thing that we as implementation scientists can really bring to prioritization, is not just to be looking at the most beautiful interventions and ideas, but also really putting that lens on when we're prioritizing what is a kind of implementable idea, and that is a really helpful additional element to build into prioritization.
And I think also, Annette, going a step further, I've had experience of adapting or trying to adapt a program that came out of the US to help parents of children, preschool children with signs of early behavioural problems. And it just didn't work. And we had great coaching of our staff from the US, and they all got accredited in the program, et cetera, et cetera. But it just didn't work in the Australian context, and partly because maybe we didn't have the degree of poverty and issues that are quite seen in the US, that's where the program was more successful in those families who are more disadvantaged to start with. But it really taught me, yes, you need to make sure it's implementable in your context. Have you got the right healthcare practitioners, etc.? But also, even if you do, you still need to do some testing of it, even if you have adapted it, because you may find it's not good bang for buck, it's not effective or cost effective. You have to unpick that further. But yes, good lesson learned. And still 15 years later, I get the odd person from government saying, what about this program? I go, well, we did try that, but it didn't work in Australia. Yeah, so yeah.
And that was
sorry.
So that was really interesting with this mental health implementation work we were doing in the UK, because actually we then had some sites kind of trying out these different ideas to see how implementable and spreadable they were. And we were kind of assuming that the sites would need a lot of support to think about implementation, but actually the kind of implementation literacy in the UK has really risen. So actually the sites were really in a good way to think about, to bring an implementation lens and to be thinking about things like adaptation to local context. And so it was really, I guess, heartening that those kind of ideas have really spread out widely, so that people could take these ideas and be thinking these really deeply about what it means to take something into your context and to help your service users, rather than kind of blindly taking ideas that tick some implementation boxes and assuming they're going to work for you.
Yeah.
So that I thought was a really nice shift that I wasn't expecting, but maybe so that was great.
And I think I always feel sort of in implementation science and implementation, I've spent a lot of time as an embedded research, but it's very much about to get that balance, isn't it, between that rigor of academic implementation science and the real life of either being in clinical practice, in the community, wherever it is you're working. So how do we bring those two together? It's kind of optimally kind of thing. We've just had a question pop into the chat, so I shall hold on to my next question that I had for you both, but I will come back to it. But Belinda asks, thanks Belinda for asking a question. That's great. What about balancing all stakeholders' interpretations and perspectives of prioritisation? Is this not a significant barrier we need to tackle first? I see much disconnect between different stakeholders on this concept of prioritisation.
Yeah, that's great question. I've never got anywhere without a shared vision. And so when I first started, once, you're thinking about any sort of project or priority setting, you've got to think, who are your stakeholders? Who do you need around the table? And what is your shared vision around that? And is it that you want better outcomes for the population X? And if you can start to have some sort of shared vision, that can then sometimes help bring those disparate groups into some sort of alignment. And then certainly with our childhood adversity, when we did our national resource allocation survey, we could segment priorities by health, social care, justice, lived experience, education. And we could see, and actually they actually quite aligned quite well. There were a few, differences in priority 3 and 4 and 4 and 5 in different rankings, but actually the most of them came out pretty much in a similar way. And I think because we framed it about, how can we really address childhood adversity and lead to better outcomes for children and families in Australia. So there was a common goal that was understood and shared. And I think that helped us. But there was nuance, obviously, in those responses, but we could quantify that through that national allocation approach, resource allocation approach.
Thanks, Harriet. And Annette, have you got any thoughts about this balancing stakeholders' interpretations?
I think it's really, really challenging. One of the first programs I worked on was a program in the UK, which was around the aging population, and older people who were very engaged in the program were really keen for the government to address kind of their kind of level of pension provision, and that was not on the table for discussion as part of this program. And the government were very clear about that, but it meant there was a sort of shadow over the program as a whole, because it was like, well, this is what matters to, those are the things that matter to you, and the idea of shared priorities was missing. I think what I really like about some processes like experience-based co-design is they give that space in the process to really bring everybody's priorities to the table. And the way that they do that is starting the process with professional, so particularly staff in kind of hospitals and other services coming together, and patients and families coming together separately, and starting the process separately so that people can discuss their priorities, and then bringing them together to look at shared areas. And actually, the examples I've been involved in there, they haven't necessarily only pursued the things that were of interest to everyone. So they've kind of run in the experience-based co-design process, you set up subgroups to design solutions. And in that process, there would be groups that involved kind of staff from the hospital and patients and families. And then there were some that were just patients and families, and some that were just staff. But they were all considered important enough to let run and to come up with their solutions. So I think that's a process that has space to let different priorities breathe and grow, to grow these kind of organic, kind of quality improvement kind of design solutions. But the reality of a lot of prioritization is we do have a kind of limited agenda. And so it's being very clear about that. And it's better when you can set an agenda together, absolutely.
Yeah, you're right. We don't always get that opportunity to have a totally blank canvas, do we? Very often we have got that complex context that we're coming into, and we can look at certain parts of it, which is, I think that comes back to your the hyper rationalism that we can have as researchers, is that we can come in and go, well, we know we want to look at A, B, and C, and it's kind of like, so I don't know why you're coming in and asking to talk about your pension, because they weren't on the table in the first place. So no, that's it's kind of like it's that bringing us all together, isn't it? I've got just one more question about setting priorities from Sadia. Thank you, Sadia, for joining us from Pakistan. Please guide me about how implementations or interventions get affected by interpersonal communication gaps and social diversity of views existing among different stakeholders. I wonder if either of you have got any thoughts about that.
Yeah, so this is an area we've only just started thinking deeply about, I would say, in the UK. And I think it's often because these stakeholder engagement processes are quite intensive in terms of the time you're asking of people, they can be quite skewed towards groups in the population who've got the time or skills or confidence to engage in those processes. So I think we are trying to be a little more thoughtful about what it means to reach out and really make these processes more participatory for more diverse groups of people. Because otherwise there's a bit of a danger that you're kind of actually layering some more exclusion on people by pursuing priorities that aren't everybody's priorities. So I think it's a really important area and something we're probably just turning our attention to now, but critical for the work we do in implementation if we want implementation to be inclusive and not to be widening inequalities, but addressing them.
Yeah, absolutely. Addressing the needs. Harriet.
And I just think understanding each other's language when we talk about social diversity and, you know, really checking if you don't understand what someone's meaning or saying, just ask, what do you mean by that? I saw, you know, because as we know, we'll have an interpretation of something, the policymaker will call it something else. You know, and abbreviations, you know, EBM, is that evidence-based medicine or express breast milk? You know, it's completely different things in different contexts. That's just a silly example. But that's, you know, so often we just presume we know what someone else is talking about and we've got the completely wrong end of the stick, and we need to take time, as Annette was saying, to listen, to ask. And I think particularly with that social diversity, you need to be able to do that and understand it.
I'm just going to move on slightly from prioritisation now. We've started talking about this already around sort of identifying solutions. And Harriet, you've already given an example, but I'm interested in around this, how we go about adapting our interventions or maybe our implementation strategies to suit the needs of our local populations. And Harriet, you just gave that example from the US that just didn't fly at all. What would you do different if you saw something overseas now and you thought, oh, that could be great for our population? What would you do if you were to try and adapt it to the...
I would spend so much more time on co-design with the end users. So what the mistake we made was we lifted up that program, we did the US training, we chose our workforce here, you know, psychologists, and we just went, go. It's a protocolized, manualized program. I'm just thinking out of COVID, we set up, I blatantly ripped off the Massachusetts Child Psychiatry Access Program, which has been going for 30 years in the States, which enables frontline workers to get access to a child psychiatrist for advice around managing kids' mental health. That was a huge program with behavioural therapists and psychiatrists. We were just starting really small, and Saturday mornings, because that was the only time people could do it on Zoom, we just ran a series of co-design sessions with local general practitioners, well child nurses, occupational therapists, psychologists, paediatricians, the mental health service at our hospital, and what we call as our primary healthcare network. So they're a commissioning body responsible for primary care services in Australia. And we held several sessions saying this is a model in the US. What it's been shown to do is let GPs and frontline workers have ready access to, you know, training and communities of practice and guidance and advice from a psychiatrist. How would you want it to run? When would you want it to run? How often? What topics would you like, etc.? And so we ended up with this, you know, really it's in 5th year of running. It's ensured, you know, increased confidence and competence in frontline workers to manage kids' mental health. We've reduced referrals to our tertiary mental health system. We've reduced worker burnout because they now have a community of practice, and we've won a Victorian Public Healthcare Award for it. So it really came back to really good co-design from the get-go.
Taking that time at the beginning. Yeah, thank you. They're all really great, useful steps and a great example. Thanks, Harriet. And Annette, I know when we've spoken previously, we've talked about that role of creativity that can play in this kind of meeting the needs of our local communities. I wonder if you could talk a little bit to that.
Yeah, and I guess this is drawing on another co-design example, actually, was when one of these experience-based co-design processes we were involved in, most of the priorities were shared, but one of the priorities identified, one group of patients had been through intensive care services. So it was about how to improve intensive care experiences. And actually, their main priority wasn't around improving what happened in the hospital, but what happened afterwards in terms of aftercare. They were experiencing kind of quite traumatic flashbacks to kind of vivid hallucinations they'd had while they'd been in intensive care. And this didn't feature anywhere in the kind of discharge information, and they were seen from this service perspective as a big success because they got to go home and they weren't under the care of the hospital anymore. But they were finding this really difficult to live with. None of the clinical staff joined that group, so it was a group entirely of kind of patients and their relatives. But they went off in such a creative sort of direction. So they basically set up a self-help group. So when people got discharged, they could get information about this group, they could join the group. And then one of the members of the group had she'd experienced these hallucinations about being a bird in a bird's nest. And so she was a set designer, I think, and she built this big bird's nest, and she would take it and to groups to have something to talk around. And so to start that conversation with something that people could touch and kind of experience. And she also came back into the service to talk to staff about, this, just to share her experience and talk to them about how important it was to send people home knowing they could get some support if they were experiencing this. So I'm not sure any clinical service improvement program would come up with a bird's nest, but no, it was such a beautiful example. And actually, in terms of the beyond the hospital walls, all of that work was going on in that space, and wasn't using any resources from within the system, but was really helping people's sort of discharge experience to be an actual success rather than a sort of a clinically perceived success, but just filling out some of those gaps.
Yeah, if we think about sort of patient reported outcomes rather than our KPIs that we might have, sort of length of stay and, as you say, all those kinds of metrics that we would put under clinical, but this is actually really starting to tick the box of improving that life beyond the hospital walls.
Yeah. And that beyond the hospital walls is about seeing the whole person, isn't it, rather than just their kind of clinical symptoms.
Yeah, absolutely. Mariana has popped a question in the chat. Thanks very much, Mariana. And Mariana says, there are other disciplines, e.g. service design, and that may have tools like user journey mapping that we can usefully leverage in implementation work. Are these tools that you've used before? And if so, how?
Yeah, so we've certainly used patient journey mapping and coming up with personas, and that's when we were designing these one-stop shops for children and families to get integrated health and social care. And so one of my postdocs led a fantastic sort of sprint design model, and very much used the double diamond design, which we can talk about and put in the resources later on, but the persona journey. So, 3 different journeys of different children, one from refugee background, etc., etc. And that really helped us design the components of a model that would be family friendly, welcoming, and a workforce that would be effective. And then we are just thinking about Annette's creative approach. We at a much smaller end of the spectrum, we took one of the things what families really wanted, a friendly, family welcoming front door to the hub, physical front door, because you come in, it was a pretty dull, sterile space. And so we actually went out with a black and white sort of mock-up of the current space, and we went out to shopping centres. Because it was in and out of COVID in Melbourne, and we had a trestle table and the staff stood there and they got kids to draw what they wanted as they got into the hub, and what would make them feel welcome and what would make the families feel welcome. And we got over 100 drawings, and that was just a fantastic way of getting pretty, cheaply done, rapid feedback. And that came out of the persona journeys as one of the 8 core components of our hub. One had to be a family-friendly entry. Or what does that look like? What does that mean? Let's take it out to the community we're building the hub in.
And these are really beautiful examples that you're both giving. It's because we're talking about beyond the hospital walls, but we often need to be talking about the hospital care as well. And it's that sort of link in and out. And so really great examples. Thank you. Mariana's just added a quick follow-up question. Sorry, Mariana, I should have spotted that before when I asked your last question. And she's asked around, clearly co-design is an important approach to contextualization. I think we'd all agree with that. Yet the willingness, and this is a question that I had saved up in the back of my mind. So thank you very much, Mariana, for asking this. I'm very grateful to you. Yet the willingness to invest in this from a time and resources perspective can sometimes be limited. How might you make the case to fund holders, government, funding bodies, maybe philanthropy, to make the case for them to invest in this? What would your arguments be?
It's a great question. I mean,
It is.
I think now, because particularly around experience-based co-design and some of the kind of established quality improvement techniques, I see them now in funding proposals as part of that kind of, upfront element of a program. So very much thinking about, will this work in this context? So you see it articulated. The challenge I see and coming up against in terms of funding, because it's not really very expensive. And one of the things we did with experience-based co-designers look at speeding it up, because they can be quite, time intensive. So that's was often the challenges about how long these processes take. So addressing that feels important. The challenge from funding bodies is about specificity of what you're going to do next. And so it's that trust that you're going to do your co-design work and trust us that we'll take something from that and this is what we'll do with it, but we can't be very specific about that. And so that a little bit depends on a kind of panel and how much they're prepared. They recognize that's the reality of the process, and how much they're prepared to kind of trust you to do that. I think that's why maybe it's kind of something to think about sometimes with some of these smaller funding pots, that you can use it as a sort of stage one of something to think, actually, this has helped me really design a kind of robust, implementable idea. I guess for me, one of the challenges in this space is the iteration between what emerges when we do quality improvement and co-design work, and what we know from the research evidence about interventions and implementation. So, for example, in our experience-based co-design work, we had a theme around lung cancer patients, and the patients wanted, they were concerned about what happened when people left the kind of the big hospital and went back to their local hospital. And so they wanted information to be given to patients about that. And so their solution was, we should design a leaflet. And so we know from a implementation perspective, the leaflet is not going to be that useful, or is part of a wider, more complex intervention. A leaflet alone is not going to make that, and certainly not for everybody. So how we make sure we play that into those processes, what we know about implementation strategies, implementation materials, and making sure we don't kind of have all that brilliant energy going into the co-design and then using it to come up with a kind of a solution that we know isn't going to fly.
And I think
the danger there.
It is, and I think you can go into your co-design with fixed elements and flexible elements, and that can sometimes counter that. And just to get back to that last question about convincing your funders, I think we've won that battle in Australia, and I think I see that in the UK grant calls as well. If you haven't got co-design consumer input, your grant's not going to get up. But I think that's been hard won. Nothing about us without us has become a very common catch cry. And I think it's convincing your funders that if we're going to make something that's going to be taken up and it's going to be sustained, the end users have got to be part of the co-design. Otherwise, we're going to make mistakes and it's not going to work, and it's not going to work in the workflow or the funding environment or whatever else it might be. And I think you need to come up with some good case studies of examples where things have had a lot of money put into them, but failed spectacularly because co-design wasn't done.
Yeah, absolutely. And I think this is something that sort of here in Australia, we can learn massively from our First Nations people, because everything that any work that we do with Aboriginal and Torres Strait Islander people, before we even get to evidence-based co-design, there's got to be that building of relationships, there's got to be that building of trust, and I just think they've been doing this for years, and I feel that we're kind of like, we're coming to the party, and we've got a lot to learn there. Now, Sadia has asked another question. Let me see if I can read this to you. Creativity embedded with local culture preservation spirit, I think, can be more effective. What is your opinion in this regard? So I think that's the sort of the local culture. Maybe that's the local community culture and creativity about bringing those together. Is that more effective, or do we sometimes see a clash?
It's probably not something I've done, to be honest. So I don't think I've got the expertise to answer that question or the experience to answer that question.
That's
Yep.
quite reasonable because we are roaming far and wide.
Yeah, and I think this has been the kind of implementation in a sort of global international development context has always had more of a participatory strand to it, always a sense that this needs to be part of the way of thinking. And so I think it is kind of recognized, and we could learn a lot from that work that's been done more internationally, particularly around kind of also issues like resourcing, you know, where there hasn't been as much resource to put into implementation. So what has been done, so that other kind of creativity that happens there. So I think it's a really, you know, this feels to me like particularly the area around kind of working in partnership, being engaged, that has been more of a kind of global agenda, more of a global South agenda that we could learn so much more from.
Yeah, absolutely. Thank you, Annette. I'm very aware that actually our time is sort of rapidly running out, and we've really kind of just talked about identifying the problems and identifying solutions and that kind of thing. Can I just spend a little bit of time talking with you and finding out your views about that process of implementation? What do you think are some of those bigger challenges when we're looking at interventions that are beyond the hospital walls? And what are some of the must-dos? We've talked a lot about, sort of engaging the community and, sort of experience-based co-design. Are there any other kind of things that we should be thinking about at that point where we're actually doing the do?
Lots, I'd say. A couple of my lessons learned is you can't set and forget. So you can't do your co-design, think you've got your model implemented and it all runs smoothly. And an example I had was there was a particular condition at our hospital. There was a 1-year waiting list for families to see the specialist for this condition. I thought that sounds ridiculous. I'm sure we can train pediatricians in the community to manage this condition. So we set up this training program, we co-designed it, we ran it, and sure enough, children got seen in 2 months rather than 12 months. I just thought that would continue on because it was clearly so effective. And then a new head of department came along who did not like the subtext was not fully said aloud to me, but the subtext was we have public and private healthcare in Australia, and the subtext was if you're going to devolve this care to a set of people in the community, you're taking away from the private specialists doing this care. And that model was scuppered because of that. So my lesson learned was you have to keep that relationship stakeholder engagement going.
Yeah. And that
Throughout
feeds
implementation.
beautifully back into what Annette was saying sort of earlier on about that power and politics and sort of some of those things that you don't necessarily sort of see before you kind of get to that point. I don't know, Annette, what are your thoughts?
Yeah, I mean, I think that relationships piece is key. We talk all the time when we talk about working more in partnership about just how important it is to build relationships between the key stakeholders, but also those senior people who can block as well as facilitate an intervention are so important. So when I guess the James Lind Alliance talk about that kind of prioritization, the process being so who you have in that process. And then, of course, the challenge for implementation is that you're always implementing, but those key people move and change all the time, as in Harriet's example. And so what you do about that. I think we did some implementation work on a program, another US kind of manualized program, which is called Patient and Family Centered Care in the UK. So we were looking, that was a program for end of life care. And we were looking particularly at what are the active elements of this intervention, what do we have to defend of this as things change and resources get strapped. And there was one particular part of the interventions that had 6 components, but there was one bit that without that was the sort of magic ingredient. And if you weren't doing that, it wasn't about adherence and making sure you were, it was about, that was where the magic lay in this intervention. And interestingly, getting to the bottom of where the resistance came to doing that wasn't actually about kind of leadership or resources or anything. It was actually because it made people feel quite uncomfortable to do it. And that was the point. It sort of made people, you had to sit down alongside your patient and look out at the service you were providing. And people were so busy in their roles that they rarely had an opportunity to do that. And when they did, it did make them feel quite uncomfortable. And some of the things were very fixable, you know, like having people's doors held open with bins and putting people having end of life care in a busy corridor for good reasons, that they wanted to be able to check in on them frequently, but actually meaning they were in a really kind of noisy and, you know, not particularly pleasant environment. So getting to that point, I think, when you're thinking about keeping things going, keeping those priorities live, about what do we have to hang on to here, and being able to articulate why is really important. Because often with these, particularly the US manualized programs, they build up to this super luscious model in terms of the components, and not all of them are essential. But we're typically implementing, say we take something from the US to the UK, in a depleted resource environment from how that's been implemented there, and then that's even more so in other countries. So that's a very real part of the process of keeping priorities live, I think, is thinking about what do we have to hold on to here.
Yes. And I'm really feeling from both of you about that sort of that dynamic nature of implementation, and you know, sort of keeping on top of things, or as you were just saying, Annette, about sort of, you know, we might lose resources or something might change, and so that sort of continuing with that iterative nature. And I think that probably feeds really nicely into a question that I'm interested in, is around how do you go about planning for evaluation? Again, if we take from sort of within the hospital setting, we often do that thing like length of stay or maybe pain or meds or whatever kind of thing. But when we're starting to think about this, when we're going further and beyond and working with the community, how do you go about thinking about evaluation in that real life setting?
I think, again, that's something you've got to do from the get-go, obviously. So you see plenty of programs that are up and running, and then the government, or often the government doesn't, but sometimes they say, let's evaluate it, and the data's just not there because it's never been set up. So it's thinking about that right from the conception of your project. It's understanding what data is already available, and, you know, I've been looking at models of care to keep children out of hospital. So I can use some existing data on admissions and readmissions to the emergency department and into hospital. But you've got to understand your data quality too. Can it actually do what you want it to do and answer the question you want it to answer? And then you need to go to your stakeholders and say, well, what matters for you as an outcome? And that can be your funders, your managers, your clinicians, your patient groups, etc. And then you craft your evaluation strategy around those stakeholders, the existing data, and what you might need to collect in addition.
Yeah, lovely. Thank you.
Yeah.
Do you want to add to that?
I mean, I agree. And I think the only thing I would add is that this has always been a really important part of our work on implementation science, is to build that culture where people are seeing the value of collecting their data. And I think that often is quite a hard journey to go on until you see the results, until you see that actually to a commissioner, you can say what your throughput of patients have been, how you've improved discharge, kept people out of hospital, all those things that we want to know about our health service. So I think that being supportive of that, you know, because it is something that we know how to do, you know, that's what, you know, we're kind of trained in. I think that important point that Harriet made about using existing data where we can. One of the things that's come up from the work on research practice partnerships that are kind of now all over the world, that kind of a different model where you're trying to work together to identify priorities and produce research together. In that process, often the questions that come from those partnerships aren't about landing big research contracts. They're about, help me with my data about my school or my hospital or my social care service. Help me understand what my data tells me about the people in my service. And so some of that, I think, is a little of our outreach beyond the kind of university walls to say, well, let us help you with to make your data useful to you, and then see how this data, you know, may add on to that. And so that, I think we could help more with that, rather than feeling like we're putting a lot of data burden on the people we work with.
And I had a lovely experience of that. Across 5 hospitals, we ran a program to try and reduce unnecessarily colonoscopies, surveillance colonoscopies, because the waiting lists are long, and we thought that perhaps patients were being brought back too soon. So we had an audit process against the national guidelines, and for a particular service, they saw that 20% of their patients were recalled too soon for a colonoscopy. And so they use that to go to their hospital with a business case to give them some extra time to actually properly audit their patients and properly set up a system to ensure the patients were recalled at the correct time interval and not too soon. And then that freed up more spots for more colonoscopies for patients on the waiting list. And the head of the gastroenterology department was absolutely delighted that he'd been given a chance to take part in this research project and have data collected on his service that then got him some extra time and funding in a very strapped environment for his service to do this work. So yeah, so you can get absolute wins if you're measuring the right things for what people care about.
Yeah. And that leads really quite nicely. Laura Spencer's asked a question. Laura's from King's Business School, and Laura's interested in whether you have had any experience engaging with local businesses, either as an employers or service providers or local community stakeholders in health-related participation engagements, which I think is a great question.
Yeah.
Either of you had any experience here with sort of bringing business in?
We've been working with care providers rather than with health, but it's been very interesting because I think one of the things we've sort of maybe talked around a little bit here is actually to do this kind of work, you need to have some shared values. And so how you have that conversation with different stakeholders, particularly when they're coming from like a different perspective, it doesn't mean you can't have shared values around a piece of work, but that conversation is so important. So we often focus on the practices and structures around working with stakeholders, but coming to a shared set of values for the work is really, really important. And so I think that's been something we didn't think about enough with our work with care home provider, that they had some very different goals, and actually they're thinking about what a university was kind of as a sort of as a provider of a kind of information and research service, and we were trying to work together in a partnership. So there's real learning for us there about how we do that more in the future, because I think there will be more interest in building those. In the UK, we've been building these commercial research collaborations, so they've been thinking very carefully about how to put some real resource in to make this work better in the future.
And an interesting area, isn't it? I agree. I think we're going to go into it more. Just one really, can I ask you a really, really speedy question, really speedy answers, so we'll wrap up on time. But Belinda's come back again. Thanks, Belinda. A current conversation between Harriet and Annette makes me dare to be courageous enough to ask how we minimise stakeholder egos. They are sadly such a barrier to progressing implementation of anything, exclamation mark. Would either of you have anything that you'd like to add or respond to Belinda on?
Look, it's challenging, isn't it? Can you change stakeholders? Ideally, that would be if you've got an ego that you just can't surmount. Are there other groups you can go to and work with? There's usually not just one player in the field. Consumers are your friends. If you have a really strong consumer who can get up and tell their story and their experience, that for me has worked really well. But if you've got really someone who's incredibly egotistical and you just think, God, I can't work with you for the next 1, 2, 3 years, I would be looking at alternatives. Yep.
Yeah, some of those mono-focused sort of people. I don't know, Annette, is there anything you'd like to pop into that?
No, I think that it is a massive challenge. We probably don't talk about it enough. We have quite a rational conversation about stakeholders, but it's a and it comes up all the time.
Yeah.
And sometimes, normally you can work around people, but sometimes you can't. And then what do you do? And when somebody said to me, we're waiting for them to retire, that didn't feel like a good implementation solution.
But the final thing you do is find out what is it they're really after, and do they want their name in lights, or is there something that you can do that is not really going to hinder what you want to do, but gives them some kudos, fantastic, or whatever they need.
Well, Annette, Harriet, it just leaves me to say thank you so much for this conversation today. And it's just been an absolute pleasure to speak with both of you and to share some of the questions from the floor. It's been a real pleasure. Just before we wrap up, I just want to remind people again about the Evidence and Implementation Summit It's going to be here in Melbourne in October. You'll see that abstracts are open and the expression of interest to do workshops closes much quicker, so get those in sooner. But we'd be delighted to see some of you here in Melbourne in October. And so thank you very much, everybody, for joining us, and look forward to seeing you at the next one of these EIS webinars. Good evening.
Thanks, everyone.